for today's webinar. This webinar is virtually a great scientific fest. We have uh, the presence of Professor Venkatram and all the national and international faculties who would be enlightening us on today's event. And today's event is held in collaboration with International Society of Hypertension (ISH) as well as the World Hypertension League on the auspicious occasion of the World Hypertension Day. So I think it's very, very important to still spread the awareness of hypertension, more so in our countries where a large part of the population still needs to be, clinicians and the population still needs to be aware. And the topic for today's webinar is eliminating the residual risk in hypertension, the new normal blood pressure and guidelines. I think recently both the US hypertension guidelines as well as the European hypertension guidelines, they have announced a change, as well as the new guidelines from the ISH has come. So in the light of this, I think what is the new normal for blood pressure that needs to be still spelled out by the experts. And to preside over today's function, we are very fortunate to have Professor Venkatram. I think he needs no introduction to our audience in India as well as internationally, but more so in India, because all of us, he is at the foremost expert of hypertension. I have been very fortunate to have been interacting with him initially during my postgraduate days. And then recently, when he came back from US, I was really fortunate in 2011, I was really fortunate that at the same time I was working on chlorthalidone, and I had the fortune of interacting with him very closely, and he is virtually a mentor to us and has really guided us on how to work in the area of hypertension and hypertension therapy. So for the continuations, for the formality, I would just introduce him. He is a director, Apollo Institute for Blood Pressure Management and Apollo Hospitals, Hyderabad currently. And he is also director, World Hypertension League, South Asia region, editor-in-chief of the Hypertension Journal, director, Texas Blood Pressure Institute, Dallas, USA, where he has worked very closely with the legendary figure in hypertension. And he is Dean, India Campus, McGill University, Sydney, Australia, and among the founder members of the American Society of Hypertension, and also held positions in American Society of Hypertension. He is past president of the Texas Indo-American Institute and director, academics and scientific affairs, Indian Society of Hypertension. And he has been conferred the Lifetime Achievement Award, the Moser Award for committee. And he has authored more than 300 publications and has written chapters and four books authored on hypertension. And I think he's still writing a book on hypertension, which we are eagerly awaiting on that, because his experience of last so many years, which will be very, very useful to you. Then we have an international faculty led by Professor Michael Weber, who is the associate chair with us. And then we have other dignitaries on the dais. Among, I think, Professor JPS Sani has joined in, and Professor Paul Welton has also joined, who has been the writer of the 2017 AHA-ASCC guideline on hypertension. So without waiting any further, I would straight away request Professor Venkatram sir to start today's deliberation and proceed further. I think, sir, can you take over?
Thank you very much, Anil. It's my pleasure to introduce the co-chair of this program, Dr. Michael Weber. People who have spent lifetime in this field, it is common to say no need to introduce, but it's only proper formality, academic exercise for the audience. Dr. Michael Weber, as you know, is a kind of an encyclopedia of hypertension, has devoted all his life for the science and practice of hypertension. And he was first at Cornell Medical College in New York, and then He started a hypertension clinical pharmacology program at University of California, Irvine, and developed a hypertension clinical program at the Veterans Administration Hospital, Long Beach, and had also a center for hypertension evaluation and management. And subsequently, he was president of the American Society of Hypertension and a permanent member of the International Society of Hypertension. And he is playing a very major role in further advancement of the mission of the World Hypertension League in his multiple capacities, especially in creating a forum for the World Hypertension League, medical journals, etc. And he continues to maintain strong interest in clinical hypertension. He is a professor of medicine in the Division of Cardiovascular Diseases at State University of New York, State University of New York, downstate in New York, where he is also serving as the associate dean. And he's going to be the co-chair, and he's going to have brief remarks. And then after that, he has asked us to be excused since he has got some other commitment. And that is what, after Dr. Weber's narrative, we'll have, no, actually, I'm sorry. We'll now have a message from the president of the International Society of Hypertension, after which we'll have Dr. Weber's narrative. If somebody could play Alta Schutz's message.
A warm word of welcome to every person joining this very important and exciting webinar. My name is Alta Schutte, immediate past president of the International Society of Hypertension, joining you from Sydney, Australia. Today I represent the International Society of Hypertension, and I'm absolutely delighted to join forces and support this initiative by the World Hypertension League. The program for today seems very relevant and with excellent speakers, so I have no doubt that on the eve of World Hypertension Day, this will be a very successful webinar. We are all used to celebrate World Hypertension Day on 17th of May each year, but this year has been different in so many ways, as I'm convinced that every single person joining this call has been affected in some sense by COVID-19 this year. But commendable by the World Hypertension League to continue and to celebrate this day 5 months later in October. We cannot let COVID-19 or any other global challenge divert our attention to keep raising awareness for the leading risk factor for death in the world, raised blood pressure. With more than 10 million people dying needlessly every year due to raised blood pressure, we need to strongly collaborate and strengthen activities to improve the situation. Today we learned that patients with hypertension have a 2 to 3-fold higher risk of death when infected with COVID-19. So much greater the reason to focus on this year's World Hypertension Day theme. And this theme includes 3 simple aspects: measure your blood pressure accurately, control it, and live longer. A simple yet striking theme. Colleagues, I also wish to stress to you today that we all need to work aggressively towards treating hypertension more effectively in India and globally. We realize that in lower resource settings there are additional challenges, and that is why the recent 2020 ISH hypertension guidelines have recommended essential and optimal standards of care, taking into account the differences in the availability of resources around the world. The ISH guidelines also indicate that we need to target blood pressure to less than 130 over 80 millimeters of mercury. If a patient's blood pressure is not on target, we need to follow the next steps and intensify treatment by either doubling the dose or adding another agent. Colleagues, I leave you with this message. Physician treatment inertia is real, and we need to be vigilant and aggressive, otherwise risk is not sufficiently reduced. And finally, I wish you all a highly successful meeting and encourage everyone to spread the message of World Hypertension Day, not only today and tomorrow, but also beyond. Thank you and best wishes for a successful meeting.
Well, we appreciate, Alta could not join because there was a time change in Sydney. So it was past midnight for her. So we certainly appreciated her message. Now I have already introduced Dr. Michael Weber. Then he will give his comments and then he will introduce the speakers, and the flow will be according to the agenda that is already in front of you. Michael, the floor or the screen is all yours.
Well, thank you, Venkata, and let me say what a pleasure it is to be part of this program. I have the good fortune to be very actively engaged with the World Hypertension League, and it's a real pleasure to see that three of us on this program are actually on the board of the World Hypertension League. Yourself, of course, it's already been mentioned that you head up the World Hypertension League South Asia activities, and of course Professor Paul Welton. Paul happens to be our president-elect and very much in the leadership of our organization. So this is very exciting for us because, as you already heard from Alta Schutte, World Hypertension Day is a very big part of what we believe in, getting the world, and it's the lay people of the world, not just the experts and the doctors, getting everybody to understand the importance of hypertension and the importance of diagnosing it, finding it, and treating it effectively. And that's really a great deal of what we're going to be talking about today. So let me start out by testing my own skills with this Zoom system and choosing slides to share. I don't know, Venkata, please tell me if the slides are on the screen or not.
Not yet, not yet. You have a share screen symbol at the right lower side of your screen.
Yeah, I pressed that already.
You did? Then it should come. If anybody from the organizers, if not, will not showing.
Well, you know what I'll do? I'm going to go back. Okay, now.
Yeah, it looks like it's, yeah.
Okay, now you see them?
Now please open the PPT.
Yeah, now I think you just have to.
Okay.
Right. Those are your slides.
Okay. You see all that?
Yes.
Okay. So finally, you can understand why in my office, anytime anything needs to be done, I get thrown out the door and my assistant takes over. Well, we're going to be talking today about eliminating the residual risk in hypertension, because we've come to understand that hypertension, even though it is the most common and perhaps in many ways the most important of the risk factors for cardiovascular disease, in fact identified by the World Health Organization as the major factor worldwide in premature death and disability, we still have to think of it as part of a bigger picture. And despite the apparent reduction in blood pressure when we treat patients, many of them continue to have an increased risk for early cardiovascular disease. So in a way, what we've got to focus on is getting rid of those residual risks. And I think you all know what they are. They're lipid disorders, they're diabetes, they're smoking. There's the usual array of risks, obesity, of course, at the center of it in many cases. So how do we deal with those things? That is the critical issue. This is a visual representation of the problem. And forgive me if this is a somewhat older slide, but it makes the point quite beautifully. If we look on the left for men and women, we see the likelihood of dying of people who've got perfectly normal blood pressure all along. They don't need treatment. Then if we go to the next column, we see people with hypertension who've been treated and had their blood pressures reduced to recommended levels, typically 140/90, below 140/90. Though you'll hear from Professor Welton shortly that that may not be good enough. And you can see already just at 140/90, there's a 30 to 40% increase in risk. So that's not good. We would like to get down to no increase in risk. And what we see, and finally on the right side of this slide, if you've got hypertension, even if it's treated but not adequately controlled down to recommended levels, we're looking at close to double the risk of cardiovascular events. So clearly we need to do a great deal more. So our program today, I'm happy to say, will update you on the latest guidelines for hypertension, including new treatment targets. And two of the issues that I wanted to highlight, because they carry a great deal of importance, particularly for practitioners in India, is first of all, that the guidelines are now focusing more clearly, not on just saying use a diuretic when appropriate, but suggesting that we use longer acting, more powerful diuretics, for instance, chlorthalidone, which now is available in relatively low doses, making it relatively easy to use, relatively free of the typical metabolic side effects that it used to cause, and hopefully contributing more to controlling blood pressure. And then an interesting issue, the role of beta blockers in hypertension, because even though these older drugs in some ways are not quite as popular now as they used to be for treating hypertension, and I think that's a reasonable perspective, because after all, we do have some more modern drugs with perhaps better outcomes data. In India, the story may be somewhat different, and we're going to be hearing an excellent discussion about that very soon, so that beta blockers could be still very important worldwide, of course, in hypertension. Don't forget, there are many conditions where beta blockers must be used: heart failure, atrial fibrillation rate control, angina, and so forth. So there's plenty of need for them, and we need to talk about them considerably more. But I wanted to show you this. It's just a brand new paper published in the Journal of the American Medical Association. The chief author was Paul Muntner, who's a very distinguished public health expert in the United States, worldwide, I would go on to say. And he points out something that should get us very worried, because this is the proportion of adults in the United States whose blood pressure has been controlled during treatment. And we can see good news over the years. It's gone better, 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 and better. And then finally, about 5 or 6 years ago, it started going down again. Relatively fewer people have their blood pressure adequately controlled. And that is a very, very concerning piece of information. What is happening that's making us deviate from that great momentum we had created, where we were improving the control of hypertension? We seem to have taken a little bit of a step backward. One of the things that could help is a new app, a hypertension app called Hypertension Connect. This is available in India, brought by IPCA as a service to the hypertension community. And you can see on this list a whole bunch of things that this app is able to give you, including live academic sessions, access to the recent issues of Hypertension Journal, incidentally edited by Venkata Ram, and a whole pool of slide presentations dealing with hypertension management, and finally the opportunity to interact with colleagues, ask questions, and share ideas. This could be a very exciting step forward. So let's talk about today's program very quickly. It'll start with Professor Paul Welton, who's at the Tulane Medical School, a highly distinguished leader in public health, and particularly in the realm of hypertension. He is the chair of the current United States hypertension guidelines. And I should also say, probably has played a bigger part in making us rethink our attitude towards hypertension by his chairmanship of the SPRINT study. And I'm sure we'll be hearing about the SPRINT trial. It's probably one of the most important landmark studies in hypertension ever carried out. And I'm really looking forward to hearing Paul discuss this whole area of how guidelines are based on hard clinical evidence. And I think that'll be a very pivotal talk for us and very relevant to World Hypertension Day. Dr. Sawhney, who you already heard mentioned by Dr. Ram, is a very highly respected cardiologist and researcher in lipid disorders. Clearly, lipid disorders are a big part of the hypertension picture. And should we give everybody a statin if they've got high blood pressure? Well, I'm not going to get into that. I'm not the expert Dr. Sawhney is, and I'm very much looking forward to his discussion, this very important issue. Dr. Manjunath, who's a cardiologist and the director of one of the major cardiovascular programs and institutes in Asia, will talk about beta blockers. And I've already talked a little bit about this, that particularly in Asia and particularly in India, beta blockers probably still have a very important part to play in protecting patients. And then our host, Dr. Venkata Ram, will provide a summary of the new recommended blood pressure levels for community and control of hypertension. And they are obviously a little different from traditional levels, perhaps somewhat more aggressive, so perhaps somewhat lower. And if there's enough time, he may touch on the current hot topic of COVID-19 and what on earth do we do about drugs that block the renin-angiotensin system? Are they good? Are they bad? Or doesn't it make any difference? And then finally, I hope you'll stay around for what will be a very lively discussion period where audience can ask questions and you'll hear lively discussion by our distinguished faculty. So with that, let me just say again how delighted we all are that you've joined us for this World Hypertension Day acknowledgement. I don't mind saying celebration. In a way, it is a celebration. It's a celebration of our commitment to getting blood pressure under control. And I do want to thank the organizers for the hard work that has made this possible. So now it's my pleasure to introduce our first distinguished presenter, Professor Paul Welton. And Dr. Welton is going to talk about the United States guidelines, perhaps other guidelines as well, and share with us where we ought to be going in our care of hypertension patients. Paul, it's over to you.
Well, thank you, Michael. It's a special privilege and pleasure to join my colleagues on the board of the World Hypertension League and my colleagues in India. My only regret is that I would love to be there in person with you in India, but it's wonderful that virtual technology allows us to be with you this evening. I am going to speak on the topic. Just share slides here. And, take that to full screen. There we go. So I'm going to speak on the topic of intensive blood pressure control and global public health tonight. I have no conflicts of interest. And I want to just start by saying, where are we worldwide? And I've participated with colleagues in my department over a number of years trying to understand the global burden of disease from high blood pressure. And if we look at the traditional cut points of 140/90, it's an enormous burden, certainly over 1 billion, closer to 1.3 billion these days. And of those individuals with a high cut point for definition of hypertension, only 46% or so, or less than half, worldwide are even aware that their pressure is high. So it is silent, as we know. And only about a third of them are being treated. And at the end of the day, even to a cut point of 140/90, which we will later, I think all, or at least I will say, is too high. Even at that cut point, less than 14% of people with high blood pressure are being controlled. So less than 1 in 7 adults with high blood pressure are being controlled, even to 140/90. And if you look at the larger countries that are middle or low income, that's less than 8%. So we are not at all where we want to be. Now, when we look at blood pressure, it'll come as no surprise to you, because you probably know this data as well as any of us, that it's a striking relationship with cardiovascular disease. And I show in the 2 left-hand panels here, pooling of cohort studies. Now, in cohort studies, what we typically do is we get people who are healthy. We exclude people with the outcomes. They don't have coronary heart disease, they don't have stroke. And then we look at the exposure, in this case, level of blood pressure, and we follow over time to see if they get the event. So what we see here is a striking relationship between usual levels of blood pressure, in this case systolic, but you could show the same thing for diastolic, and the occurrence of events. Stroke and heart attack is what, and ischemic heart disease is what I'm showing. But you could also look at heart failure, you could look at kidney disease, anything that's vascular, there's a striking relationship. And there is no threshold for risk. There's no point at which the body says, whoa, I've got hypertension, I'm now at risk. The body doesn't have hypertension receptors, it has recognition of level of blood pressure. And you see that's a very striking, steep relationship in young people, because really in young people, when we see high blood pressure, it's usually the only risk factor that is present. It's a little less steep in older people, but that's because there are many risk factors at play. And of course, when you get to older age, your risk, your absolute risk, is much higher than it is at younger age. So at every age, it's important. It's important for men, it's important for women. It's very striking. And even in the clinical setting, which is a little different, because in the clinical setting, usually we're taking care of people with several comorbidities. The average risk in a clinical setting for cardiovascular disease is really quite high. But when you go to a clinical setting, and I'm showing here an electronic health record linkage study, it's a large one, over 1.25 million people, you see exactly the same pattern, shown in a reverse way here, but a striking relationship between blood pressure and the outcomes, no evidence of a threshold for risk. So clearly, blood pressure is a very important risk factor for cardiovascular events. And when we look at risk factors, it seems to be the most important one that we can manage. This is a study, one of several, done by the Global Burden of Disease Study Group. And they're looking here at 84 different risk factors: behavioral, environmental, occupational, and metabolic risk factors. And when they look at that level of blood pressure that I showed you in the previous slide, systolic of 110 to 115 or above, it was the most important risk factor. And you can see they estimated that worldwide it was causing more than 10 million deaths per year. And even more striking, if you took deaths plus poor quality of life, what we call disability adjusted life years, striking 218 million people affected per year. So enormously important. It's the only risk factor that's more important, or seems to be more important, than cigarette smoking, which in itself is a huge risk factor. So if there was one risk factor that one would want to target, it's high blood pressure. And of course, we know how to target it, which is the great beauty of it. And when we look worldwide to say, where is the burden of disease? Well, it's really striking that China is here, India is here. They're the 2 major contributors. So if you're looking for where burden of disease from high blood pressure is, it's right in India. India, China, very important to us in the US. It's our #1 cause of death, but still on a worldwide basis, we're down here. We contribute only a very small number of events. And of course, the predominant type of events are ischemic coronary heart disease, non-ischemic stroke, hemorrhagic stroke, and ischemic stroke. Those are the three big ones, followed by chronic kidney disease. So all the culprits that we think about normally. And when we think about blood pressure management, the first things to say, of course, level of blood pressure is very important, but I want to stress something that was mentioned by Dr. Schutte early on. That is, for blood pressure level, it's absolutely vital that we do accurate blood pressure measurements. And unfortunately, that doesn't often happen in practice. So if we're really going to use the information from the clinical trials and from those cohort studies, they measure blood pressure pretty darn well. And it's important in practice to be careful about the measurement of blood pressure. There are beautiful helps on the website for the World Hypertension League, including a very nice course, a recent edition, for how to train people to measure blood pressure accurately. And it's important to use an average of blood pressure. As you well know, within any visit, you get tremendous variability in blood pressure, and you get tremendous variability from visit to visit. So getting a window on blood pressure in the office requires one to get not only several pressures at one sitting, but to get the patient back a second time. And it's important to look at that level of blood pressure in the context of overall cardiovascular risk, because if somebody has a low overall cardiovascular risk, they're not likely to get an event in the near future. If the goal of treatment is to prevent an event, then it's hard to do much in that person. On the other hand, if they have a high level of risk, then intervening with risk factors is very, very valuable. And finally, I just want to mention, if it's feasible, it's important to get out-of-office blood pressure measurements, not only to confirm the small window that we get for high office blood pressures, but to recognize masked hypertension, high normal in the office, but high outside. Those people have about the same risk of sustained hypertension. Recognize white coat hypertension, high in the office, but normal outside. We may overtreat those individuals. And for out-of-office blood pressures in the US, typically, although ambulatory blood pressure measurements are terrific, it's more practical for us to use home blood pressure measurements. And that's very helpful also in the management of high blood pressure, because it allows us to engage patients and empower them to be a part of their own care. And we know that that improves the control of high blood pressure. So as we think about treatment, of course, non-pharmacological therapy, which is mostly improving lifestyle, is fundamentally important, because that's what causes high blood pressure in most people. But that should be combined with drug therapy in certain people. And the choice of drugs really depends on whether there is a compelling reason to particularly choose an agent. Perhaps somebody has heart failure, perhaps they have kidney disease with heavy proteinuria. That would lead you to a particular agent. When there's no compelling indication, the real key here is getting blood pressure down. That's much more important than the choice of drugs, as long as you're using sensible drugs. And as we looked at our guideline in the US, and the Europeans came to the same conclusion, there were 4 drug classes that were unequivocally better than placebo for preventing events. The diuretics, especially the long-acting diuretics, either chlorthalidone, which is the one that's been most commonly used in trials, or if you don't have that, indapamide is a good alternative. They're probably the single best agents, but also the calcium channel blockers are very good, particularly the dihydropyridines. Angiotensin converting enzyme inhibitor has been well proven to be effective, and angiotensin receptor blockers also well proven, not as many trials as the others, but well proven. So those 4 unequivocally better. We didn't recommend, nor did the Europeans, beta blockers for first step therapy, but that may reflect the fact that the trials that have been done have used the older beta blockers that are not as good, and we'll hear more about that in a moment. So the other thing that's important to know is that most people require 2 drugs, and for most people, they should initially be treated with 2 drugs. If you can do it in a single pill combination, that is even better because you'll get better adherence. Unfortunately for us in the United States, many of those single pill combinations have poor choice of drugs, particularly the diuretics. They often have a short-acting diuretic and often at doses that have never been shown to be effective in trials. So that's the conundrum, I think, with some of the single pill combinations, but better combinations are coming out. It's especially important that we start with two drugs and somebody who has a high starting level of blood pressure. It should be fairly obvious. And for us in the United States, for African Americans, because they're disproportionately at risk for any given level of blood pressure. We recommended getting down to a goal systolic, diastolic, less than 130 over 80. And in older adults, we said just focus on systolic blood pressure. And the reason we did that is there are many trials that have shown the benefit of getting to less than 130 over 80. And there are many meta-analyses that pool these trials that show that. Perhaps statistically, the most powerful one is one done by my colleague at Tulane, Josh Bundy, or led by him. And we were able to show there, whatever the goal, getting to a lower pressure was always better. Let me just go down to the very lowest goal that we looked at, 120 over 124. You can see if you compare that to a high control level of blood pressure, very striking effects. But even down here, 120, 124 versus 125, 129, still statistically significant. We saw that pattern consistently for every goal level of blood pressure. We saw it for all cardiovascular events. We saw it for stroke and heart attack individually. We saw it whether you included or excluded particular trials like SPRINT. And we weren't the only one. We saw it whether you used the approach I'm showing here, a network meta-analysis, or the more traditional direct meta-analysis. And many others have found the same thing, including for our guideline, we had an independent evidence review committee. We asked them specifically, look at less than 130 over 80, tell us if that is well proven, and they did a meta-analysis, came back and said, absolutely, for all the major outcomes, it's very well proven. So I think the data are very convincing here that lower goal blood pressures than we recommended in the past make sense. And all the major English language guidelines now adhere to that approach. So if we go across just the 4 major English language guidelines, the Australian guideline recommends getting down to less than 120. Obviously, careful follow-up, that's a given when you're doing intensive lowering of blood pressure. And they give that their strongest recommendation. The Canadians also say on high risk, I should have said this is on high risk patients, the type of patients that go into our clinical trials, and the type of patients that you're seeing in clinical practice, that in that setting, less 120 or less makes sense, and they say shared decision making. They give it a grade B, and the only reason that's their second highest level of recommendation, the only reason they gave it a B versus an A is they said they'd like to see more trials at the 120 level. They were very convinced at the 130. We said, well, our committee as a whole, we were absolutely convinced 130 over 80. It didn't stop somebody going to less than 120 over 80. In fact, I keep my own blood pressures less than 120, and very simply on a chlorthalidone and the ACE inhibitor, low dose. We give it our highest recommendation. This is class of recommendation, the strongest recommendation. In the high-risk individuals, type of individuals studied in the trials, we said in lower risk individuals, we also recommended it, but we didn't really give it quite a strong recommendation. And we said in older adults, go to systolic less than 130, and we gave that our highest recommendation. And lastly, the Europeans have a sort of a 2-step approach. They say first get to less than 140 over 90. And as long as your patient is doing well, press on and get down to at least a systolic of 130. And if you can get down to less than 130, they say don't go to less than 120. We didn't say that in the US. And they have a slightly higher goal for older adults, 130 to 139, and also for patients with kidney disease. They say go to a diastolic less than 80, but not less than 70. So all these guidelines are pretty similar. I personally like, probably biased, our own approach in the US, which is go straight to the goal that you're trying to get to. I worry with a two-step approach that you got therapeutic inertia. People say, well, I got to less than 140 over 90. So, you know, I've done pretty well. I'm satisfied with that. So in any case, we're much more similar in our recommendations than we are different. Now, I want to just talk about a few special groups. The first one is older individuals. And it's natural in older individuals that we might worry that, well, if we lower blood pressure too much, perhaps we won't perfuse the vital organs. Perhaps we won't perfuse the coronary arteries or the cerebrovascular arteries. Perhaps somebody will get hypertension. Maybe they'll get syncope. Maybe they'll fall over and they'll get a fracture or something worse than that. Well, in trials, and we've had a number of trials now on older individuals, always lower has been way better than higher. Not slightly better, but way better. And I show as an example here, the most recent trial, the systolic blood pressure intervention trial, or SPRINT. And we had quite a few individuals that were at older age. We had over 2,500 individuals who were 75 years of age or older at the start of the trial. They derived exactly the same relative benefit as everyone in the trial. And of course, they started at much higher risk. So in absolute terms, they got much greater benefits. They didn't have to treat many individuals to prevent events. And it wasn't just the major cardiovascular events, it was all-cause mortality that was reduced. So this is a very powerful intervention for older people. You know, I should say in older people, what you often see as an event is heart failure, and it's a very awful outcome to have. So preventing it is really important. Heart failure and stroke are very, very common in older people. The other thing that older people worry about is cognitive impairment and dementia. We don't want to get that. It's a poor quality of life. And it's something we looked at very carefully in SPRINT. And in SPRINT, we looked at cognitive impairment, and we saw within 12 months a big difference between the intensively treated group and the standard treatment group. It was much less common in the intensively treated group, and that pattern continued throughout the trial, and it continued even after the trial. We didn't see many dementia events during the trial. They tend to be slower to evolve than cardiovascular events. So if you stop your trial due to cardiovascular benefit, which is what we did in SPRINT, you won't see enough dementia events. But we did do post-trial follow-up, and then we started to see the dementia events as we went out. And we did a randomized comparison, and we looked at the composite, which is a sensible composite of cognitive impairment and dementia. And when we looked at that composite, it was significantly different. We also looked at MRI findings in a subgroup. And there is an MRI finding that you often get with dementia. It is dense white matter lesions. And we saw less of those dense white matter lesions in the groups that were, in the individuals that were treated more intensively. So there's strong suggestive evidence that intensive blood pressure lowering will also slow and perhaps prevent cognitive impairment for sure, and dementia possibly, likely. And that makes sense because, you know, if you think about it, a certain amount of dementia is small vessel disease, it's atherosclerotic. You would think that blood pressure lowering should prevent it. And there are several trials now that are ongoing looking at this question. The other subgroup I want to talk about briefly is diabetes, because you would imagine that intensive blood pressure lowering would be very beneficial here. The largest trial that has looked at it in diabetics is ACCORD. Previous trials that have looked at lower versus higher have always shown that lower is better. Accord, or like Sprint, had a target of less than 120, so it was the most intensively treated group. And Accord, unlike Sprint, used a different design. In Sprint, we had a very straightforward two-arm trial, randomized either to intensive lowering of blood pressure or to standard blood pressure control. In Accord, they wanted to try to answer two questions, and they used what's called a factorial design. So they wanted to know not only is intensive lowering of blood pressure beneficial compared to standard, but is intensive glycemic control better than standard glycemic control? Get two answers, two questions answered for the price of one. It's wonderful when it works. The problem with this sort of design is that you make a big assumption and you can't test that assumption until the trial is done. So you assume there's going to be no interaction between these two interventions. And unfortunately, sometimes there is, and I've been caught by that, and that's why I've reverted to liking the more simple designs better than these sorts of designs. Unfortunately, in Accord, there was very clear interaction. So when we look at Accord and we compare it to Sprint, here is Sprint, here is the beneficial effect of intensive blood pressure lowering. When we looked at Accord, we didn't quite see that benefit. Now you'll see it's very close to overall benefit, and there was a secondary benefit of reducing strokes. But, you know, in the way that the analysis was pre-planned, it didn't quite make it. When you split it out and look separately at those who were intensively treated to lower their blood pressure, but had standard glycemic control, they seemed to do better. And it was the group that had intensive glycemic control that didn't seem to do better. And that's a very interesting group to look at. So here they are when they're getting intensive glycemic control. There's no evidence that intensive lowering of blood pressure is beneficial. That intensive glycemic control was stopped because, as you may know, it caused harm. More people died in that harm, so it was stopped. It was very interesting that after it was stopped, when they went to standard glycemic control, the pattern that you saw was identical to Sprint. We quickly saw that intensive blood pressure lowering seemed to be very beneficial, almost identical to the benefits that we saw in Sprint. So I think based on these sort of data and many other data, there's strong supportive evidence for intensive lowering of blood pressure in diabetics, as long as you're following what is now recommended, standard glycemic control. And that's what we recommended in our guideline. And again, there are several trials and large trials in Brazil and China that are asking this question. So we'll get more evidence. And the last thing I want to say is when you look at approaches that have a more intensive efforts to identify and control high blood pressure at lower levels, like our ACC-AHA guideline, and you compare them to other approaches that are less intensive, what you see is estimates that you would have a very big difference in the benefits. You would see a much larger benefit with more intensive management than with less intensive management. Not terribly surprising, that's what we would expect. So I will summarize by saying high blood pressure is undoubtedly a key risk factor. I would say the key risk factor for control and prevention of atherosclerotic cardiovascular disease and non-atherosclerotic cardiovascular disease. Not the only risk factor, but it's a really important one. Blood pressure related risk and our management of it is greatly influenced by the presence of other risk factors. So we need to look at all culprits together. Unfortunately, at the moment, we seem to have very poor control, even to levels that are really pretty conservative, less than 140/90. And that's especially true in the high population, middle and low income countries. Our contemporary guidelines, more or less across the board, recommend much lower targets for blood pressure than we did in our previous goals. We treat adults much more functionally now, and say as long as they are community dwelling and ambulatory, treat them about the same way as you would others. Same for diabetics. better awareness, treatment, and control of high blood pressure, especially to these lower blood pressure targets, would be expected to result in a huge health benefit for the individual and for the health of the population, especially in a country like India. So thank you for the invitation, and it's a great pleasure to be with you tonight. I look forward to hearing the other speakers.
Thank you. Thank you, Paul. Really wonderful demonstration of the global health and how it is related to the levels of blood pressure and interaction with other coexisting morbid identifiers of cardiovascular risk. I do want to mention to the audience, ladies and gentlemen, Paul may not like it, but I'll say it. You have heard from somebody who has dedicated his entire life for decreasing the disease burden on the community, who designed the studies, who made the studies were completed properly, and therefore and most of his studies are incorporated in all the guidelines, not just American guidelines, European guidelines, international guidelines. So what you have heard is from somebody who has got a direct experience, lifelong experience in dealing with this important problem. And you are all privileged and blessed to have heard from him directly. You're not hearing from me, but you heard from somebody who is really the master of this. So with that, and he will participate in the discussion. Dr. Sani has already been introduced. So if I can hand over the screen to JPS, and he will take us through GPS of residual risk.
Thank you, Dr. Ram and Dr. Weber for kind introduction, Dr. Paul Wilton, and dear colleagues. On the occasion of this World Hypertension Day, I thought we'll be discussing about a very important topic, relevant topic, the importance of lipid control to eliminate the residual risk in patients with hypertension. Dear friends, as you are all aware that even in spite of effective control of blood pressure with good antihypertensive drugs to the goal level, a lot of hypertensive population, they continue to have a residual risk of cardiovascular events. And this is basically contributed by the associated risk factors, which are the tune of 50 to 80% every hypertensive population, as per the guidelines recently published 2020 International Society of Hypertension Guidelines. The associated risk factors, the common are the diabetes, around 20% of patient, lipid disorders is 30% increases with the age. But about the dyslipidemia as a co-risk factor with hypertension, one important finding is that it is a hidden, a silent risk factor. It has no symptom. Diabetes has some symptom, hypertension has some symptom, dyslipidemia has no symptoms. So we have to eagerly look for to detect this associated risk factor in every hypertensive population. And we are also aware of the fact that each individual risk factor cause cardiovascular events, but it is the interplay of the multiple risk factor which causes cardiovascular risk exponentially. So the rule is that to do the absolute risk reduction in every patient of hypertension. And this is supported by the INTERHEART study also, where we have learned that the risk factors, when do not have the additive value, they are multiplicative. For example, if a hypertension causes cardiovascular disease by 3-fold and dyslipidemia by 4-fold, if both are present in same patient, then it is not 4 plus 3, but it is 4 into 3, comes to 12-fold. So that is the importance of coexisting risk factors. For example, in hypertension and dyslipidemia, there is a significant increase in cardiovascular morbidity and mortality. So now coming to how to manage this risk factors together. So I will take the help of the ESC guideline 2018 for hypertension and ESC guideline for 2019 for dyslipidemia management. Both the guidelines have given us very nicely. They have given the risk stratification of individuals, very high risk population, moderate and a low risk population. The very high risk population is basically those who are suffering from cardiovascular disease and with hypertension, of course, and the high risk population will be a single risk factor like grade 3 hypertension, 180 or 110, or a hypertensive patient who has got target organ disease like left ventricular hypertrophy. So both of them have been included as high risk population. Grade 2 hypertension population are now considered to be moderate risk hypertensive population. Now coming to the lipid guidelines, which are based on the recent clinical trials on antilipidemic drugs, and now they have intensified the lipid lowering target goals, and very high risk population, like for example hypertension with cardiovascular disease, probably we have to reduce the LDL to less than 55 milligram. For high risk population are the patient, those who are having BP more than 180, 110, or diabetic with hypertension, or hypertension with LVH. These are the patients, those who are classified as high risk population. The goal is to reduce the LDL to 70 milligram. The moderate risk population, as I said, is hypertension stage 2. There probably one should reduce the LDL to less than 100 milligram. So what I want to say that risk factors, since the common denominator for risk factor of diabetes or hypertension or smoking is LDL. So the basic emphasis is to reduce the LDL in this population to the target level, then only we'll be able to achieve the optimal reduction of cardiovascular events. And we could give you an example of diabetes, as we have learned from various clinical trials and good data, which shows that it is important to control glycemia, but it is more important to reduce cholesterol and blood pressure in a diabetic population. You can see here, this data is very clear that if a diabetic patient population, if the prescription is not having a statin, probably it is an incomplete prescription. So because of that, probably good data coming from the large clinical trials, mainly on lipids and diabetes. Now we have learned that majority of the diabetic patient will have to keep their LDL cholesterol less than 70 milligram, and very high risk, of course, 55. Coming back to the hypertension, let me go through the intermediate risk population, which is now evidence available from the HOPE-3 trial. I will go briefly because of the paucity of time. So HOPE-3 trial, as if all of you are aware of the fact, there's a double-blind randomized clinical trial where we have used the BP lowering strategy and using the candesartan hydrochlorothiazide, and lipid lowering strategy using rosuvastatin 10 milligram together or separately and compared with the placebo. In intermediate risk population, those who are non-diabetic, those who are not having any cardiovascular disease, these are the patient, elderly patient 55 and 65 years, male and female. They have central obesity, they have some smoking history, family history of premature disease. If you look into the data, approximately 40% of the patients were also hypertensive in all the three groups, like the combination of candesartan and rosuvastatin was one group, rosuvastatin alone, second group, and alone antihypertensive group, and they were compared with the placebo. The average LDL was 127 milligram. Most of these hypertensive patients were well-controlled hypertensive patients on the calcium channel blocker or beta blocker. So coming to the results of this study, very interesting finding, which we found that compared to the combo treatment, the only rosuvastatin treatment have shown similar result. So those patients, those who have controlled blood pressure, by just adding rosuvastatin to this group of patients, statin has reduced the cardiovascular events. So the controlled blood pressure patients will also show the further reduction of cardiovascular events. And those people, only area where the combination treatment worked better was the patient, those who have got baseline blood pressure more than 140 millimeter. But those who have reduced blood pressure in the lower blood pressure group, it shows that there was a deleterious effect of adding antihypertensive drug. What we learned from this, the final message which came from HOPE-3 is that all patients at intermediate risk should be put on statin. Antihypertensive drug should be given only to those patients with high blood pressure, and benefit of lowering blood pressure in hypertensive patient is doubled if the LDL is also lowered simultaneously. So this gives us a clear-cut evidence that the intermediate risk population, it is important, even if the blood pressure is controlled and they have the lipid lowering drugs have a significant effect of reducing the further cardiovascular events. Other trial, which was the ESCORT lipid lowering part, like ESCORT BP trial, and one of the more than 10,000 patients on lipid lowering arm, where patients of hypertension, high risk hypertensive population, they were the hypertensive population more than 55 years of age with multiple risk factors, at least 3 risk factors. They were given the 2 line of treatment, one the calcium channel blocker with the ACE inhibitor versus the beta blocker and diuretic. And along with that, an arm of atorvastatin versus placebo was given to patients those whose cholesterol was less than 250. The trial was prematurely stalled because of overwhelming results in favor of statin. And these are the patients, those who had no underlying cardiovascular disease. The subgroup analysis shows the patient, even with less than 200 milligram of total cholesterol, the beneficial effect was seen. Now we have a recent report from the legacy cohort study of the same trial for 16 years after the trial was completed, have still continued to show that beneficial effect of statin in this group of patients, probably because of the stabilization of the plaques in this population. So that shows that high-risk population, the reduction of cholesterol is also very important. Same trial also gave us a very important information. There is a potential synergy between the lipid-lowering drugs and blood pressure-lowering drug. Now, as we all know, the dyslipidemia is known to cause upregulation of Ang2, causes endothelial dysfunction, reduction of nitric oxide, and thereby some increase in blood pressure is expected. And statin can block all this effect of the dyslipidemia by reducing the cholesterol and also having pleiotropic effect. So it can theoretically reduce blood pressure. At the same time, we have seen the antihypertensive drugs like the RAS blockers, calcium channel blocker, particularly RAS blocker, they blunt the angiotensin 2. Calcium channel blocker along with RAS blocker also improves endothelial function, improves the nitric oxide, and they reduce the blood pressure by this mechanism. Now, since both of these drugs, statin and this drug, they work through the same mechanism, they have a complementary action or synergistic action. Another important finding is that the RAS blocker and calcium channel blocker do not have any adverse effect on the lipid, unlike the statins' adverse effect on sugar levels. And because of this factor, it looks like they have a synergistic action. And the same trial, when they look into the atorvastatin group population, comparing the two different group of drugs used for the antihypertensive efficacy, the amlodipine and RAS blocker group showed much more beneficial effect in reduction of cardiovascular events compared to atenolol-based treatment. So that shows that, as the guideline now shows, the particularly European guideline, that most of the patient to begin with should be started on RAS blocker or calcium channel blocker combination. And then if you want to need statin, probably they will have a complementary action and more beneficial effect to reduce the cardiovascular events. So coming to the type of conclusion to say that for the management of dyslipidemia in hypertensive population, I think probably should not be based on the baseline cholesterol. It may be important to do a lipid profile and to find out the baseline lipid profile, but I think it should be more based on the risk assessment of a hypertensive population. So for example, a patient of hypertension with atherosclerotic cardiovascular disease, we would like to keep the LDL less than 55. And for that, I think majority of this patient will be requiring high dose of statin because anyway, they are needed for atherosclerotic cardiovascular disease. Now, coming to the stage 3 hypertensive population, hypertension with diabetes, hypertension with target organ disease, and hypertension with probably non-diabetic risk factor, I will say maybe smoking. These are the people probably the target should be below 70 milligrams as per the guidelines. And for that, I think moderate doses of statin is good enough. Plain hypertensive patient, if they have LDL more than 100, probably reducing to less than 100 will be a way to go. For them, the low dose of statin is probably safe and effective. As we all know in the society, in the community as a whole, the average LDL cholesterol is more than 100 milligrams. So it seems that every hypertensive population probably, or majority of the population of hypertension will be requiring some doses of statin to take care of the residual cardiovascular risk. So lower the better is good for LDL, as we have seen for all the guidelines for diabetes and lipid guidelines. May not be true for hypertension always, but earlier the better will be very effective for both hypertension and lipid management. So every patient, we need not wait for the later stage to intensify the treatment. I think it's better to pick up all the coexisting risk factors in any risk factor patient like hypertension and treat them effectively, adequately. Then only probably will be in a position to reduce the residual risk and reduce the cardiovascular events. So in conclusion, ladies and gentlemen, I would like to say the combination of hypertension and dyslipidemia are common and they raise the cardiovascular risk exponentially. And fortunately, the concomitant use of the lipid-lowering drug like statin and along with antihypertensive drug, particularly with the class of RAS blocker and calcium channel blocker, having a synergistic effect will be showing much more beneficial effect in this population. And guidelines now recommend to be aggressive in lowering the in high-risk patient of hypertension. For moderate risk of patients, low to moderate risk of population, probably the keeping the LDL below 100 may be a good idea as far as the guideline says. So it seems that majority of the patient of hypertension probably will be needing statin therapy to take care of the residual risk of reducing the cardiovascular events. I'm sure in future the guidelines will work in one direction as they have worked for diabetes. It looks like for diabetic population, irrespective of cholesterol, we have to reduce the LDL cholesterol in diabetic. Similarly, I personally feel that the hypertension population will also be behaving in the same way, irrespective of LDL cholesterol in future. Maybe we'll have some evidence to show that if you want to really reduce the residual risk of hypertension patient who have adequately controlled their hypertension, then we have to go and treat them with statin. Thank you very much for your kind attention.
Thank you, JPS, for a actually wonderful summation, which was not short, but it was complete. Actually, it was really complete. Ladies and gentlemen, we will have further discussion, but you will notice that what Dr. Sani has suggested is that if you control the blood pressure, that is only a partial answer to cardiovascular, removing the cardiovascular disease burden. So in your patients, when you measure the blood pressure, you should also measure their lipids, because both of them go together. If one is high, other is normal, the benefits are basically neutralized. So you have to synergize the benefits by synergistic treatment. And that's very, very important to keep in mind to remove the residual risk in hypertension. It's an extremely serious matter. One should not take it lightly. Really, one should not take it lightly. You should always think that your patient is going to have stroke tomorrow. You should always think that your patient might have a heart attack tomorrow. So the time is today that where you tackle multiple risk factors. When you know somebody's age, weight, and blood pressure, it is incomplete unless you know the patient's lipids also. That is a message Dr. Sani has given, and it's a very important message to keep in our daily practices. Now we will go on to another topic that has already been mentioned, the importance of it for South Asia by Dr. Weber. I have mentioned it also. And so we'll now go to Dr. Manjunath, who is just a fantastic clinical cardiologist, originator of one of the best cardiovascular institutes in Asia. And it's our privilege that somebody of that stature is joining us. While he is coming on, I know that his partners are also logged in. Is Dr. Manjunath coming in?
Yeah.
Okay. While Dr. Manjunath, while you're setting your slides, I do want to mention something, because Paul Welton is listening and others are there. 2 years ago, when I brought Dr. Peter McCullough, the chief of cardiology at Baylor, to Jayadeva Institute, when he made rounds in the morning and he came back in the afternoon, and he told me that next time when he comes to Bangalore, he'll bring all his fellows to your institute to see how clinical cardiology is practiced most efficiently. That's what he told me. I didn't mention to you, but I certainly remembered. So, Dr. Manjunath, the floor is all, the screen is all yours for your interpretation of the role of beta blockers in the modern paradigm of treating hypertension. Please proceed. Thank you.
Yeah. I'm audible?
Yes.
Yeah. Thank you, Professor Venkates Ram and Michael Webner and Paul Welton and Sani. It's on the eve of World Hypertension Day. It's a great thing actually to have this sort of a symposium for creating awareness, and also to create awareness among the physicians, also update the physicians regarding the importance of optimal control of blood pressure, and also along with blood pressure, cardiovascular risk Hello? Hello?
Yes.
Yeah, we can hear you.
Now, can you share the screen?
Yeah, yes, we can see the screen.
And I am not able to.
Or I will share from here.
Actually, I am not able to see the screen.
So 1 second. So are you able to see now?
No, sir. Only I am audible.
Please swipe
Yes,
your
we can hear
Initially, I
you.
was seeing the screen.
We can hear you and we can see the screen.
You are seeing the screen, sir?
We're seeing, yes, we're seeing your screen.
Please swipe
Okay,
left.
okay. But anyway, I am not able to see the screen. And anyway, my topic, I think I'm not able to see the screen. So my topic is the importance of beta blockers in cardiovascular protection in Indian patients. And of course, hypertension is the most common non-communicable diseases, accounting for nearly 25% of cardiovascular mortality and morbidity, particularly in Indian context. So, and it's also true, nearly 2/3 of hypertension is associated with other risk factors such as dyslipidemia, diabetes, or CKD, and so if you look at the pathophysiology of hypertension, we have this Page's mosaic theory of hypertension. So hypertension pathogenesis is multifactorial, as we all know. So there is a chemical factor contributing for hypertension, and the neural, particularly sympathetic overactivity, is one of the important thing, because we know that blood pressure is a product of stroke, increase in the stroke volume and peripheral vascular resistance. And we have volume contribution coming, and elasticity, because as we know that as we age, the systemic vascular resistance increases, the arteries become rigid, resulting in, that is the reason why the prevalence of hypertension goes up as we move, as we age. Then because the resistance is mainly coming at the arterial level rather than the capillaries level. It is the arteriolar resistance contributes to blood pressure. Then, of course, other contributing factors for blood pressure is cardiac output, particularly hyperkinetic type of high blood pressure have a high cardiac output, and viscosity also contributes to blood pressure. So these are some of the important players that contribute to the development of hypertension. Then we have, next slide, the 7th report of Joint National Committee. These are some of the compelling indications. See, for very long time, almost till 1980s, beta blockers were one of the standard prescription for hypertension. But this theory of central aortic pressure, knocked out the atenolol and beta blockers from the list of antihypertensive prescription. But yes, it is true with respect to atenolol, but because nearly 2/3 of hypertension do have associated risk factors, so there are some compelling indications for beta blocker. Even today, beta blocker is an important and an integral part of antihypertensive therapy, because 2/3 of hypertension do have an associated conditions or comorbidities. So hypertension with heart failure, yes, it is an important indication for beta blockers. And post-MI, ever since the Professor Alquist gave the concept of beta blockade, beta blockers continues to be an important prescription for management of post-MI, that is as a part of secondary prevention. Beta blocker, along with statins and aspirin, these are the 3 common combination of drugs we always give for in post-MI patients. So one is heart failure, second is post-MI situation, and high coronary artery disease risk. These are some of the important indications for beta blocker. In Indian context, hypertension have many hypertensives do have tachycardia. They have some sort of an hyperkinetic circulation. So particularly hypertension with tachycardia is another important indication for beta blockers. Then we have some study coming from Lancet. What is the role of atenolol as well as the clinical outcome was concerned? And in this, if you look at the atenolol versus placebo, yes, all-cause mortality was more or less same, but with respect to other non-cardiovascular mortality, it was relatively little more with atenolol. So coming to the effect of beta blockers with respect to atherosclerotic burden. So this is an ELVA study. Beta blockade decreases atherosclerotic progression in carotid intimal media thickness, because we know that some of the earliest changes of atherosclerosis is in form of intimal medial thickness. In fact, it is one of the earlier used to have this non-invasive assessment of risk assessment of atherosclerosis by doing a Doppler scan and looking at carotid intimal thickness, and of course ankle brachial index, all those things. So in this study, metoprolol succinate as given for a period of 1 year and followed up for 3 years. At the end of 3 years, there was a reduction in the progression of carotid intimal thickness. In a way, it always suggests definitely it has got some sort of an anti-atherosclerotic, relatively an effect. So another important indications for beta blocker is heart failure. So there was a time beta blockers were contraindicated for heart failure, but today there are 4 or 5 groups of drugs which has a mortality benefit in patients with heart failure. The first one is beta blockers, second ACE inhibitors or ARBs, and third is ORNI group of drugs. Then we have aldosterone antagonists, and fifth is SGLT2 inhibitors, considered to be an important prescription to heart failure. Although it has started as a diabetic drug, today it has shown a mortality benefit even in patients with heart failure with non-diabetic status. So beta blockers unquestionably is an important prescription in the management of heart failure, because if you look at the ratio of these receptors in the heart muscle, there are 80% is beta 1 receptors, and 20% is actually the beta 2 receptors. So in a setting of an heart failure, what happens? There is an alteration of this beta 1 to beta 2 receptors, and as a result, by giving beta blockade, you are upregulating the beta receptors. In a sense, what happens in a patient with a heart failure, in a myocardial catecholamine levels is reduced, but the peripheral the catecholamines increases. As a result, there is a increase in systemic vascular resistance, and as myocardium is depleted of catecholamines, their contractility is reduced. By giving beta blockade, you are going to upregulate the beta receptors. As a result, over a period of time, there are more than 12 trials. The bottom line conclusion of beta blockade in heart failure is that significantly reduces mortality. It also improves, the shorter hospital stay. It also has got an antiarrhythmic effect. So it has also reduces sudden cardiac death. So the metoprolol succinate is always preferred over a tartrate as far as heart failure is concerned. And yes, sudden cardiac death. This is another, because I have already alluded to the beta blockade reduces sympathetic activity. It has also improves the myocardial performance. In a sense, it has got an important role in sudden cardiac death. See, beta blockers, whenever you are giving beta blockers in patients with heart failure, you should not be given to those who are edematous. You have to make them euvolemic by aggressive diuretic therapy, and patients should not be on intravenous diuretics or inotropes. So you have to start with a slow dose and gradually increase. What we call it as start slow and go slow. So this is very, very important. And what is the importance of combination of ARBs and metoprolol? This is a study published way back in 2007 in patients with hypertension. When ARB alone was given, there was definitely a reduction in blood pressure. When metoprolol was added to ARB, over and above ARB antihypertensive effect, there was a significant reduction in blood pressure. So in combination of ARB and beta blocker also is a very good therapy for managing patients with hypertension. So the guidelines differ in recommending beta blockers for initial therapy in hypertension, but definitely the compelling indications for using a beta blocker is hypertension with ischemic heart disease and as a part of secondary prevention of MI. In fact, the beta block BUTS trial way back in 1987-88 conclusively, robust data coming from the trial that beta blockade given in post-MI patient reduces both mortality as well as morbidity, including sudden cardiac death. And initially it was studied for 2 years. Then this mortality reduction benefit in post-MI patients with beta blocker was seen even at the end of 5 years. So beta blockers definitely, other than atenolol, are cardioprotective and helpful. And beta blockers like metoprolol have shown to be beneficial in various outcome studies, particularly in Indian context. Beta blockers still have got an important role to play in the management of hypertension. That is hypertension with the tachycardia and some of the young hypertensives, hypertension with atrial fibrillation. These are some of the indications for beta blockers. So with this, probably I conclude. So definitely beta blockade has got a cardiovascular protection in the form of, particularly in patients with LV dysfunction or those with heart failure. And that is how we should able to manage these patients. And hypertension with the lipids already Professor Soni has alluded to. So it's very important because hypertension in isolation is only in 25% of hypertensive population, but majority do have various associated comorbidities and other illnesses. So because choosing a drug, an antihypertensive drug, is always dictated by the comorbidities or associated condition. So hypertension with heart failure, hypertension with post myocardial infarction status, hypertension with atrial fibrillation, hypertension with tachycardia. Yes, still beta blockers have got an important role to play. Hello.
Thank you, Dr. Manjunath.
Hello.
Thank you, Manjunath, for putting the beta blocker choices in the context of Indian population, in the context of concomitant medical conditions. Put it nicely, whatever data you have, they appear to have a protective effect, at least in certain categories of patients who have hypertension comorbidities. Now I want to, this is almost like a summary thing, I want to do mine. One thing I want to mention, only people like Dr. Manjunath, Paul Welton, some of these people who have followed the history for so long, he mentioned the name Raymond Alquist, which not many people will remember. Actually, he mentioned Raymond Alquist. He is the one who devised the classification of beta blockers, and his paper, original paper, was rejected by so many journals, so many top journals of today, high impact factor, whatever that means anymore. They rejected it, and finally he published in a pharmacology journal which accepted it. So it's very, very interesting. In fact, I don't want to mention the name, people who do cholesterol metabolism, who have won Nobel Prizes, their initial papers were rejected by journals in Boston, things like that, but ultimately they won the Nobel Prize. So, ladies and gentlemen, if your paper is rejected by major journal, take it as an encouragement to publish it further. So it is not a discouragement at all. In fact, one of our papers has been repeatedly rejected in the last 3 months, and we're working on the data. So that's the way it is. So, ladies and gentlemen, let me share my screen. Okay, I think it is showing. So let me just summarize. Part of it really is going to be overlap with Dr. Welton, but I'll make it very, very fast. So the normal definition of high blood pressure, and therefore the normal definition of normal blood pressure, has changed in our own lifetime, not for out of any magic, not because of any illusion, but based upon the data. What is the level of blood pressure that appears to be protective, and what is the level of blood pressure that could be harmful? This is a classification of hypertension that was proposed by American College of Cardiology, American Heart Association, and also the Indian Hypertension Guidelines and JNC. The only thing that I would like for you to see is the category of pre-hypertension was removed in the American College of Cardiology, American Heart Association guidelines, and the category of pre-hypertension was embedded or embraced as stage 1 hypertension. So one thing that has come new in 2017 is the elimination of the category of pre-hypertension and including it as a stage 1 hypertension. That means the definition of hypertension has changed in 2017. Now, this number of 130, the new number of 130 has come based upon number of evidence-based data. And this is a slide showing what happens to the outcomes when the blood pressure is less than 130 or when the blood pressure is greater than 130. You will notice when the blood pressure is greater than 130, there's no benefit at all. There's no benefit at all. So all the benefits of cardiovascular therapy for blood pressure reduction are accomplished only when the blood pressure is under 130 millimeters of mercury systolic. So ladies and gentlemen, there is a clear-cut evidence that blood pressure that is persistently above 130 is harmful, and the blood pressure systolic that is persistently less than 130 is beneficial. No doubt about it. Now, Dr. Welton has actually shown you a slide where the cardiovascular risk increases for systolic blood pressure 115. And this is actually taken from the raw data that he has shown. You will notice when the blood pressure is increased from 120 to 130 systolic, or diastolic is increased from 80 to 90, there is a 56% increase in cardiovascular mortality. There's 100% increase in stroke and myocardial infarction, and there is a significant increase in coronary heart disease. So, ladies and gentlemen, even in the so-called previous normal blood pressure, when the blood pressure shifts from 120 to 140, there is a graded increased cardiovascular risk. So what you thought 135 was fine, 140 was fine, it was not fine because it was associated with significant mortality and morbidity. And that is the reason why now we have so-called new normal levels of blood pressure. Now, this is a slide showing the definitions of hypertension according to Europeans and according to American College of Cardiology, American Heart Association. But look, the goal blood pressure is the same in both guidelines. So it does not matter how you define hypertension. The blood pressure has to be reduced to less than 130 or 80. Whichever category hypertension that you want to subscribe to is immaterial because the goal is to reduce the blood pressure to less than 130 over 80. Now, I want to make a special mention about the high risk in Indians. because the argument that I face all the time is that all the data are from somewhere else, they're not applicable to us. That is absolute nonsense, because hypertension is a hemodynamic abnormality. It is a hemodynamic malignancy. So it does not depend on your physical address, where you're living. You could be living in Mumbai and you move to somewhere else, you still carry hypertension. So you cannot say that I deserve high level of blood pressure because I am from here. Absolute nonsense. Every guideline has identified Indians as a high risk category of subjects. When I say South Asians, ladies and gentlemen, it is really in the brackets, it is Indians. So you look here at the European Society of Cardiology, European Society of Hypertension guidelines. Once you are an Indian, your risk increases by 40%. Now, American College of Cardiology, American Heart Association, in the primary prevention of cardiovascular disease, they have once again have identified Indians as being high risk category. And more recently, the International Society of Hypertension also has identified South Asian population, means Indian population, is being high risk for cardiovascular disease from hypertension. So ladies and gentlemen, do not mistake, make no mistake, all Indians are at high risk for cardiovascular disease from hypertension. So you must follow the goal blood pressure, otherwise you're exposing your patients to significant cardiovascular risk. Hypertension is the main reason for cardiovascular disease in India, and this has been shown in many, many studies. This is from a study done in Mumbai called, actually it's a Mumbai cohort study, where they looked at the ischemic heart disease risk in a population of almost 200,000 individuals. You will notice when the blood pressure goes to 130 or 140, there is a significant increase of heart disease among Indians in Bombay. So you cannot say these data are not applicable to us. In fact, these data are most applicable to us based upon what we know today. So ladies and gentlemen, this is very serious business. This is a study that we completed at Apollo, looking at risk factors for patients who present with acute stroke. Basically, the patients presented to the emergency room with acute stroke. Hemorrhagic or thromboembolic did not matter. And we found out the most common reason for the development of new stroke among Indians is hypertension, followed by diabetes, and followed by tobacco consumption. Of course, in many individuals, all these risk factors coexist together. So, this was shown again. This is something Dr. Welton has alluded to indirectly. The majority of cardiovascular events occur in people with blood pressure less than 140/90. I did not say more than 140/90. I said the majority of cardiovascular events occur in people with blood pressure less than 140/90. That means people who have blood pressure between 130 to 140, between 80 to 90, that is where highest mortality is. So ladies and gentlemen, you must forget about 140. Forget about 135. Remember 130, because anything between 130 to 140 has the highest risk of cardiovascular events, and we need to pay attention to this. The role of combination therapy has been pointed out by Dr. Welton. And this is a slide showing in the middle, you'll see two antihypertensive drugs reducing the blood pressure when they're given individually. But when you combine them, shown in the blue color, same drugs, when you combine them, the blood pressure is much lower. So ladies and gentlemen, this is drugs A and B. When you combine them, there is a greater fall in blood pressure. And that is the reason why one should use combination therapy to reduce the blood pressure to a greater degree. I will skip this slide. The role of chlorthalidone was mentioned in the introduction by Dr. Weber and pointed out by Dr. Welton also. It is a preferred diuretic on the basis of longer duration of action, and the outcomes shown in number of studies. All these, by the way, all these are called pivotal studies in hypertension that are shown on this slide, starting from 1970s to more recently Sprint. All of them have utilized chlorthalidone as one of the drugs for reducing the blood pressure. So based upon the evidence, it appears to be a preferred diuretic now in all the guidelines. Now, let me summarize the level of blood pressure. Ladies and gentlemen, in 50s, 160 by 110, in 60s, 150 by 100, 70s, 150 by 95, 80s, 140 or 90. Now in 2020, which is almost coming to a close, the normal blood pressure is 130 by 80. So ladies and gentlemen, you can't change the year. 2020 will remain 2020. But the blood pressure new normal has changed. It is 130 by 80. So don't go back to 80s, 70s, 60s, and 50s and keep on arguing that high blood pressure, this is the level. Please don't go back to the past. In 2020, the new normal blood pressure is 130 by 80. Whether we like it or not, that is the way it is. So the new normal blood pressure, we finally have an understanding. Let me comment just for about 5 minutes on the relationship between, if there is anything, between the pandemic of COVID, hypertension, and antihypertensive drugs. The controversy has been that when you give a RAS blocker, either an ACE inhibitor or ARBs, some, not all of them, they might increase the ACE2 levels. When the ACE2 levels go up, it has been suggested that the coronavirus or SARS-CoV-2 virus actually gains greater entry into the cell. So it has been suggested that increase in ACE2 that occurs with some ACE inhibitors, ARBs, might actually increase the development of COVID syndrome by increasing the entry of the coronavirus into the cell. This is the theoretical model, but it has not been proven. And if you look at the earlier fatality rates in people with COVID, you will notice that those people who had uncontrolled hypertension, they had a higher case fatality rate in COVID compared to those who did not have high blood pressure. So the take-home message is uncontrolled hypertension increases the morbidity and mortality from COVID because of cardiovascular dysfunction. So hypertension is not a risk factor for COVID, but uncontrolled hypertension is a risk factor for complications from COVID. Very, very important to keep in mind. The other thing that you have to keep in mind is the COVID mortality is related to the age. The older you are, the higher is the mortality from COVID, but this is the same age group that also has high levels of blood pressure. So high levels of blood pressure and increasing age are associated with poor cardiovascular outcomes in patients with COVID, and it should not be surprising. That is the reason why it is very important in the current pandemic to control hypertension so that the patients are not exposed to complications from COVID. This is an area that is somewhat controversial, not conclusive, but controversial. There are data suggesting people who are of Asian origin or Pacific Islanders are less prone to COVID complications compared to Caucasians and African Americans. The reason for this is not known, but this is an observation that needs to be tested or that needs to be seen by future studies, that Asian population is somewhat less prone to progression of COVID complications. So, ladies and gentlemen, the relationship between RAS blockade and COVID, the adverse relationship, there are no human data. There are no human data. It is only a theoretical hypothesis that was made in a journal that caused a lot of controversy. All the societies, professional societies, cardiovascular societies, regional and global, they have all suggested that in the current pandemic of COVID, one should continue the antihypertensive therapy, including RAS blockade, because RAS blockade might be actually protective, not harmful in patients who have COVID. So there is no conflict at all. Any recommendations from all over the world that one should continue the previous therapy, including RAS blockade, in patients who might develop COVID or its complications. So multiple studies have shown that RAS blockade does not predispose you to develop COVID. So the earlier hypothesis has been proven wrong, that the presence of RAS blockade does not aggravate any complications from COVID. Please remember this. This is very important. In fact, the earlier studies have shown that if the RAS blockade is absent in patients with COVID, you have more adverse outcomes, suggesting RAS blockade might be cardiovascular protective in patients from COVID, probably due to its effects on bradykinin, probably due to effects on Ang1-7, causing vasodilatation. So interestingly, ladies and gentlemen, the pendulum has swung. Initially, they suggested RAS blockade could be harmful in patients with COVID. Now we are at the other end of the pendulum, where RAS blockade appears to be protective in patients from COVID. A major publication is now in press, authored by Dr. Welton and co-workers on this relationship between hypertension and RAS blockade, and it is under consideration by a major journal. So the take-home message is RAS blockade should be continued for whatever indication the patient is taking and should not be discontinued in patients with COVID, because if you discontinue RAS blockade for a given indication, the underlying condition gets aggravated. So let me conclude, ladies and gentlemen, that as far as COVID and hypertension is concerned, hypertension is not a risk factor for COVID, but hypertension is a risk factor for complications in COVID, which means you're better off having normal blood pressure all the time. In case you develop COVID, at least you're not at a higher risk. So actually COVID pandemic is another reason to control the hypertension pandemic, so that the patients are not exposed to high levels of blood pressure. That is very important. And more recently, a paper has suggested that the RAS blockade should be continued in patients with COVID for whatever reason they're given, and the blood pressure should be maintained normal in the community. And this is a slide Dr. Weber showed you, the so-called residual risk in patients with treated hypertension. You will notice that patients who are treated for hypertension are still at a 30% higher cardiovascular risk despite good blood pressure control, which means you have to pay attention to new normal levels of blood pressure. You have to pay attention to lipids. You have to pay attention to diabetes, pay attention to obesity, tobacco consumption, so that you can remove this residual risk, so that the controlled hypertension has the same benefits as those who have never developed hypertension. That is our goal, is when you control the blood pressure, you must make them normotensive, and they should enjoy the same life expectancy as those who never develop hypertension. And that is a challenge we have for the World Hypertension Day 2020, World Hypertension Month 2020, and forever, is to remove this residual risk in treated hypertension so that you can provide maximum cardiovascular benefit. So with that, ladies and gentlemen, I will conclude my part of the discussion, and let me open up now for quickly we'll catch up with the questions that have come, and I'm going to direct it to the concerned person. This could be for actually not this could be. This is for Dr. Belton from Dr. Gupta in Agra. Are you comfortable with blood pressure 130/80 in the long run in patients with chronic coronary artery disease? In other words, he's implying so-called J curve, I suppose. Can you please comment?
Yes, well, thank you for the question. And my comment is J curves have been reported, and they're very common in epidemiology. We see these so-called J curve relationships with almost everything. We see it with alcohol, we see it with overweight, we see it with cholesterol, we see it with sodium. It's a very common phenomenon. And typically what happens is at the tip of that J, the lower end of blood pressure, in this instance, you've got a conundrum. Risk is up, and the question is, what's causing it? Is it low blood pressure that's causing events, or is it that people who have events can't mount high blood pressure? Most of the evidence would suggest the latter. Now, I would just tell you in SPRINT, we looked at this issue, and when we did the typical analysis where J curves have been found, that is a non-randomized analysis, and that is the only analysis where you'll see these J curves reported. People will say, we saw it in this trial. They didn't see it in a randomized comparison in the trial. They saw it in a non-randomized observational study. So when we looked in SPRINT, we saw a J or U-shaped curve. We saw it overall. We saw it actually in both arms, the intensively treated arm and the standard treatment arm. When we did the proper analysis, which is a randomized comparison, at every level on that J, you saw benefit for those who are more intensively treated. So even at the lower levels of blood pressure, where the risks seem to be high, and they are high-risk individuals, they derive benefit. We've seen something very similar in another trial called the ASK trial. So I think the problem here is that people have been doing an easy analysis, but it's not the right analysis. So always when we're treating, we have to be careful. I'm not saying there isn't, there isn't some risk, but I will say that sometimes our concern about side effects paralyzes us from doing what is best for the patient's interest. So do I have concern? Of course, at some level of blood pressure, you're going to go too low, but everything we know now is from most people in the levels that we're talking about, it's not an issue.
Thank you, Paul, for clarifying that people who have adverse outcomes at relatively low levels of blood pressure are due to underlying disease rather than driven by the blood pressure. So that's, again, interesting question that comes up all the time. If Dr. Manjunath is there, he can answer, but if he's not there, Dr. Soni will answer the usual question. The bradycardia from beta blockers, which is a pharmacological effect, of course, at what level of heart rate you feel that you should withdraw the beta blocker, because the heart rate is low, but the patient is doing great. Dr. Manjunath, are you there? If not, I'll ask Dr. Soni to start answering.
Sure. So, the bradycardia, by definition, we say less than 60. Now, it depends upon the, you see, I will take the help of some of the clinical trials, particularly like SHIFT trial, where we can see we have been using beta blocker to the maximum tolerated dose. The heart rate was more than 70. And now we have been asked to add ivabradine to reduce the heart rate, which has further reduced the cardiovascular events. On average, the trial showed that 62 to 63 was the heart rate, where it becomes the optimal heart rate in those situations where we have combined the drug and shown a further reduction of cardiovascular events. So again, as Dr. Welton has said, is that many things, everything has a U-shaped curve. There is a sweet spot everywhere. So like heart rate, high heart rate is bad, tachycardia is bad, so also bradycardia is bad. So the epidemiological study, observational studies have shown clearly that if the rate is below 50 or below 55, then there is an increased cardiovascular events.
Okay, so there was another companion question from Bhubaneswar. So basically, unless somebody has a heart block or a very severe bradycardia, the heart rates of 50 to 60 are not indication to withdraw the beta blocker as long as the patient has a normal quality of life. Is that correct?
I think this is also correct. For a hypertensive patient, I think we have seen in patient, particularly with cardiovascular disease associated, we are always very happy to keep the rate between 55 to 60 because this is a resting heart rate. And when they go to do exercise or exertion, it goes certainly beyond 60. But I think keeping between 55 to 60 for a hypertensive patient, particularly associated with CAD, I think is a good thing to do.
And another question, actually, it's young patients with hypertension who presumably have sympathetic overdrive. Something is manifest, something is not manifest. Whether guidelines do suggest anything for young hypertensive patient with sympathetic overdrive, or what do we call that, soldier's heart, whatever we used to call them. Would you recommend a particular therapeutic agent, or you let it go? I want Dr. Welton to comment, but I also want Dr. Sawhney to also give his opinion because he leads a large cardiovascular program.
Well, this is an area of great concern. It's an evidence gap. We know that the common outcome, atherosclerotic disease, it starts young. I mean, we know that teenagers, when they're autopsied, they already have atherosclerotic disease. We know my son published recently a very interesting analysis from MESA. He looked at low-risk individuals between a systolic of 90 and 130. And what he showed is cross-sectionally strong relationship with coronary artery calcium, both in single vessels and in multiple vessels. And prospectively, he showed increasing level of blood pressure, even within that range, was associated with the occurrence of other cardiovascular risk factors and cardiovascular outcomes such as stroke and heart attack. So we know that we need to focus on young people. Our problem is we have an evidence gap. We don't really have many clinical trials in that setting. And of course, we can't really do event trials. So it's a very challenging area. In our guideline, what we suggested was look at lifetime risk. You can't use the standard risk calculators because they're really based and developed around events. So they don't apply to younger people. But you can look at lifetime risk, and there's strong suggestive evidence that early treatment for people who have abnormal levels for their age is beneficial. That's what the pediatric guidelines recommend as well. So I think getting the blood pressure down is the key. In this age range, often, as you suggested, Venkata, people have sympathetic overdrive. So beta blockers and ACE inhibitors and other agents that seem to influence the sympathetic system work better in younger people. They don't work as well in older people, but they work very well in younger people. So yeah, I think there's, in my opinion, just an opinion, there's a strong place for those agents in younger people. The key here is to really monitor their pressure. If somebody has a pressure that seems very unusual for that age range, it probably makes sense to treat it, certainly with lifestyle, of course, but even with low-dose pharmacotherapy.
Right. Dr. Sawhney, very brief thing, because
Sure.
you see patients
Yes.
from Gurgaon, all those software engineers,
Yes.
all the software engineers, sympathetic overdrive.
Yes.
How do you treat them? Can you comment?
That's right. As Dr. Paul Rampton had rightly said, most of the guidelines are silent about the young population. Young means 30 to 50 years population, because studies are not supportive of that. I remember one paper, or the last guideline of European Society of Cardiology, one chapter was devoted to young hypertensive population. There they have discussed clearly, based on, I think, Swedish registry, that the young hypertensive population, one should be careful about diastolic blood pressure. This is very common, that 130 by 100 blood pressure may be a very common finding in young hypertensive population. The other group is the isolated systolic hypertension of young, where BP is around 150 by 80 or something, and they have tachycardia associated because sympathetic overdrive. Now, their suggestions was in the follow-up period of 10 years that you need not treat them. They are the people, those who need counseling, lifestyle modification, some anxiety and works well. They on follow-up do not develop hypertension. But other group 130 by 100, probably you need to pay attention, may have to use the pharmacological therapy. And that for that, the neo beta blockers probably like nebivolol, bisoprolol probably may be effective. Now we have Indian Hypertension Society, as the IHS study which was done by Aris, as you are aware, Dr. Venkat. In that, the average age of the 18,000 population from our country was 43 years. So these are the young people. And here we found we had a sympathetic overdrive associated. The heart rate was also higher in this population. So it looks like that is in this group of population, if there is a pharmacology treatment is needed, a smaller dose of a newer beta blocker, maybe which are cardioprotective beta blocker, may be effective. Maybe you have to use small dose of RAS blocker also in addition, but this is a way to treat that.
Okay, just very brief, the question that comes up, and I'm talking on behalf of the audience, is this software engineer from Microsoft will ask you, Dr. Sani, how long should I continue the beta blocker?
That's right. I think you should, if we have started after lifestyle modification, maybe for 3 months or so, and then we have decided to put him in beta blocker. You see, what I have seen, a lot of young people, those who have got reversible factor of hypertension, like they are not sleeping well, they are having obstructive sleep apnea, they are indulged in a lot of excess of salt intake, excess of alcohol, excess of smoking, they are gaining weight. So these are the people where there is some reversible factor which is playing a role. So I tell them, okay, I'm starting you on drug, but I will like you in next 6 months to 1 year to control your reversible factors. And in my opinion, including some of my OSA patients with mild hypertension, the antihypertensive drug has been withdrawn after the correction of those risk factors, particularly reduction of weight, reduction of alcohol, optimal use of salt, and the exercise program is, and high intake of potassium diet also worked well in this group of population. So I think it's not that there's a common misconception in the society, the doctor once have started antihypertensive, it will be lifelong. I think in my personal practice, this is not fact, particularly in mild hypertension.
Okay, thank you very much. Now, it's an interesting question, although it is misspelled, but it's an interesting question. They meant white coat hypertension, but it appeared on my screen as white collar hypertension, okay? Like white collar crime. Usually white collar is associated with a third word called crime. But let's not talk about white collar hypertension, white coat hypertension. This is a very perennial question, and this will continue to haunt us throughout our career. People who have occasional blood pressure, what to do with them. There are several personal viewpoints, but I want Dr. Welton to comment briefly. I know that even one elevation of blood pressure is a marker of the tendency for somebody to develop hypertension in the long run. So again, a quick summary, quick comment on white coat hypertension. Paul.
So I think really for me, what this points out is the challenge of trying to manage a lifelong risk factor based on very limited data in the office. So we get somebody in the office, it's an unusual circumstance for them, they're often nervous, and we got a couple of blood pressures, maybe we get them back a second time. That's a very small chance to try to understand what's really happening to blood pressure in that patient. I think it really shines a light on the importance of getting pressures outside the office. Obviously, anything that's done outside the office needs to be done with the same rigor and accuracy as in the office, but I mentioned a very nice course that is available free through the World Hypertension League website. So clearly we see some people, they're high in the office and they're high outside the office. That's easy. We see some people, their pressures are perfectly normal in the office, and even if we did them outside, they'd be normal. We do see very commonly two types of patients, and a much more common than I had originally understood. So one is the person who has normal in the office, but it's sort of high normal, and outside it's high. and that's masked hypertension, and they have a very high risk, just the same as sustained hypertension. And then the other one is white coat hypertension, high in the office, supposedly normal outside. Now, those people is uncertain. Their risk is closer to normal blood pressure, but they clearly are at risk for progressing to sustained hypertension. Every year, somewhere around 5 to 10% of them are going to go on to get sustained hypertension. So it's a red flag. It needs to be followed. In our guideline, we recommended non-pharm for that group. We didn't feel the drugs were indicated. There are no trials, of course, in white coat hypertension or masked hypertension. We did think, based on risk and just expert opinion, that for masked hypertension, it was sensible where it was well proven to combine drugs and non-pharm. So challenging areas. I think it really underpins the importance of understanding somebody's pressure outside the office in addition to within the office.
Okay, there are a couple of questions. I will respond, but both of you can, if you differ, please feel free to differ. Best drug for systolic hypertension. There's not such a thing as best drug, but the drugs that are modern drugs that have been used in Cysture and Cis-China have included a calcium blocking drug. So whatever combination you use, if you include a calcium channel blocking drug, that appears to have a positive outcome and also reduces the blood pressure. And then heart failure,
I would jump in, Venkata, and just say the best combination is the one that lowers blood pressure. I really think that's the key. And, you know, culturally, we vary. In the US, we think, based on meta-analysis, long-acting diuretics are probably the best. I realize you need laboratory checking. I don't really care. If somebody wants to use a calcium channel blocker in place of a diuretic, that's fine. Many times we need 3 drugs, and it's going to be a calcium channel blocker, something that blocks the renin-angiotensin system, and a diuretic. But to me, the combination is choose whatever drugs you're comfortable with and you're happy with, lower the blood pressure. That's the key to me.
Okay, there is one comment. Is there a drug resistance in hypertension, or use the pharmacological word tachyphylaxis? It used to be a phenomenon earlier on that was discovered, but I think this so-called resistance to therapy, let's use the word tachyphylaxis, is probably due to either inadequate treatment or not good volume control. Usually it is the volume control. You have to restore the volume control with a diuretic and sodium diuretic that should restore it. But typical drug resistance that you don't see it, it's not like antibiotic resistance. We don't see it. Of course, some drugs cause fluid retention like hydralazine, minoxidil. Then you have to get rid of the fluid. So the pharmacological word tachyphylaxis does not apply to antihypertensive drugs in general, as long as you correct the diuretic. Paul and Dr. Sani, feel free to. Dr. Parikh, our pharmacologist par excellence, is there. He will also comment.
I just say very quickly, in the trials, and I realize trials select people that are not necessarily exactly the same as one sees in practice. In the trials, we're consistently able to get to less than 120 with fairly simple combinations. In the US, at least, as you know, Venkata, better than me, most people with apparent resistant hypertension, the problem is adherence. They're not, for one reason or another, they're not taking the meds as prescribed. Lifestyle is the second common issue. And of course, secondary hypertension is a possibility, but I believe you're correct that true resistance to lowering blood pressure with contemporary medications and lifestyle is very, very, very uncommon. So when you see somebody whose pressure is continuing high, it's a red flag, and we ought to be looking for what's the reason, and there's usually a reason that explains it.
Dr. Parikh, our clinical pharmacologist, I saw him on the screen. Dr. Parikh, can you comment briefly about this phenomenon is really inadequate treatment or lack of a diuretic, but not pharmacological resistance? Can you comment?
Yeah, I would like to comment, sir, about how the various therapies have evolved. Like we have lipid guidelines, which first time consider the CV risk in a patient. I think those were the first. Then the diabetes guidelines, once the therapy with SGLT2 inhibitors and uh, uh, the GLP-1 receptor agonists came, they consider the CV risk and the heart failure risk and the kidney risk. But hypertension, we don't have, like if the patient is at heart failure risk, then which are the antihypertensive agents that are more effective. So I think the time has come to hypertension also. If the person is hypertensive plus more prone to coronary artery disease risk, which antihypertensive is better? Maybe we don't have enough evidence at this moment. But maybe heart failure, definitely I found that a combination of thiazide-like diuretic, long-acting diuretic works, much better in this setting. And if you consider now we have the 130/80 as a new normal, as you all emphasize, as the goal blood pressure, very rightly so. And often we find that unless you add as a thiazide-like diuretic, many patients, the blood pressure, because it's a progressive disease, you need to add more agents. Like in the diabetes, we need to add more and more agents. So finally, I think there is people are not underutilizing these all these drugs, where thiazide like diuretic is often underutilized, and people are unduly concerned about the metabolic adverse effects and all that. But with the low dose thiazide like diuretic, I think we should have a better control of the blood pressure. And from the sprint study, we got that when you want intensive blood pressure control arm, often it was in those patients, clothianol was used much more as compared to the other classes of drugs. So this is what I feel. And earlier, when the resistant hypertension blood pressure also, unless you give a thiazide diuretic, you don't call that blood pressure as resistant hypertension. So one class has to be thiazide-like diuretic. So when you now, with the intensive blood pressure control, which is being desirable to reduce the CV risk, I think the role of these classes will become more and more important. Is my humble submission.
Thank you, Dr. Parikh. So what we have now, we have one question and comment, and then we'll have a demonstration of the app, which actually I'm looking forward to it. So we're almost to the tail end. We will do it. This is a question that I'm going to paraphrase from myself. I'm going to paraphrase it. When you have a goal blood pressure that is defined, why do you need stages of hypertension? It bothered me also personally. Why do you need stages of hypertension? We don't stage diabetes. We don't stage hyperlipidemia. We don't stage tobacco. But why do you need stages of blood pressure rather than saying hypertension and normotension? Paul, can you comment on it? And then we'll go to the demonstration of the app.
Well, hypertension is, as you sort of alluded to, arbitrary. The body doesn't have hypertension receptors. It's really blood pressure. I am really sort of prefer the term high blood pressure because that's physiologically the important entity. And you're right, you could get rid of the stages. The value of staging is probably just to bring attention. So we kept 2 stages of hypertension just to say if you're at a higher stage, in other words, you have higher pressure, you're at greater risk, but that's about the only value to it. Really, you could get rid of it.
I think, sir, one stage is already eliminated by JNC7. Stage 3 was eliminated in JNC7. So 2 stages are remaining. Maybe one more, the stage will go.
It's normotension.
We try to keep it pretty simple. As we categorized, we try to keep it simple and practical in our guidelines. So 4 categories of blood pressure, 2 categories of risk, very well defined, definitive. So clinicians would know, I got to do A, I got to do B, I got to do C. I don't criticize the European guidelines, but they've got 7 categories of blood pressure and they have about 14 categories of risk. So I worry about the practicality of how you implement that. I think many times when you have very complicated approaches, they may mirror physiology better, but it becomes challenging when you're trying to implement those recommendations in practice.
Okay, thank you, Paul and Dr. Sani, Dr. Parikh. Please stay on if you're able to, based upon your time. we'll have a demonstration of the app, and then I'll have concluding remarks, which will not be dramatic. It will be very, very simple. Can I ask somebody to demonstrate the app?
Yes, sir. We are.
Your better partner in hypertension management is here. Now, the latest news from the hypertension world is at your fingertips with Hypertension Connect, a one-of-a-kind hypertension management app. Hypertension Connect is empowered with attractive features such as on homepage, watch live academic sessions from the news feed, as well as exclusive access to articles from hypertension journals. At My Profile, you can create your exclusive profile. Get all the updated information in the announcements section. The Knowledge Hub page gives you access to guidelines, hot off the press, important articles, and medical presentations related to hypertension management. In the Ask Us section, you can ask queries and interact with therapy experts. The discussion forums enables exchange of views among peers. The FAQs page has answers to questions related to hypertension management. Conferences page gives you the updates on upcoming national and global conferences. Your valuable feedback is welcome on the survey page. The miscellaneous page gives you the opportunity to participate in interesting quiz sessions. Register today to get a complimentary app and discover the many benefits of Hypertension Connect, your better partner in hypertension management.
Very much. Obviously, there's more to it. People who develop it, it's good for doctors and hopefully for the patients also. But I just hope that your spouses don't hear that the app is a better partner. I hope that it won't create any disharmony at home. So I don't think that is the implication. There are few questions here. In the interest of time, certainly in India. Fortunately, all the doctors who are asked the question, their names are here. So what we will do is we will respond to them separately. And if it's anything pertinent to our faculty, I'll call them. If I will ask them. If not, we'll do out of respect for them. We will definitely respond to those because they're sincerely asking these questions and there might be an answer and we'll try to do it. Shall we conclude, Anil? Is it anything more or shall I just make some concluding remarks?
Yeah, you can make some concluding remarks.
Okay, first of all,
before you conclude, Venkata, may I just say what a privilege it is to be with you. We have worked together over, won't say how many years, but many years. You were very nice to me earlier, but I want to return the compliment to you because you have made so many major contributions to the field of high blood pressure in the US, in India, and worldwide. And it's just a wonderful pleasure and special honor to be with you, with the other members of the panel, and with the audience tonight. And thank you for having me. I feel very, very privileged.
Thank you. Thank you, Paul. And thank you, everybody. First of all, we did hope that we have defined the levels of blood pressure, how it is important, and that the tragic slide, I call that tragic slide that Paul Welton showed, only 7.7% control in low and middle income countries. It's a tragedy that is requiring correction. So because the hypertension pandemic has been there for a long time and we have never plateaued. this pandemic, hypertension pandemic. We never plateaued at all. So we need to do that. So I hope that this program was useful to the audience and the application in clinical practice. I also want to thank the IPCA for supporting this event, International Society of Hypertension, and Dr. Paul Welton, representing World Hypertension League. I'll conclude with this, and thanks again, and have a good evening in India and good afternoon in New Orleans, and we'll sign off. Anil, any farewell message from you all, or this is it?
I think it was a great program, and the confusion around the new hypertension guidelines and new hypertension levels were cleared by the, I think, authorities himself, like Paul Welton, the chairperson of this 2017 ECCHA guideline. It was a great thing to hear him. I think thanks to you, sir, we could hear to Michael Weber, to Professor Paul Welton, and Professor J.P.S. Stanley. Of course, we always call him, and he is always there to help us in our CME programs. So it was a great occasion, and we are lucky to have IHS as collaborator and the World Hypertension League and collaborator, and with under your guidance, always we learn more and more. So it was a great evening for everybody. I hope for all the audience, it was a great evening. So with that, I think we can sign off.
Okay. All right. Thanks, and have a good evening. We'll sign off now.